My name is Aaron Oxley. I'm the Executive Director of an organisation called Results UK that does advocacy and campaigning work on a lot of international development issues, including TB. One of the hats I wear is that I'm also the developed country NGO constituency representative to the Stop TB Partnership Coordinating Board. I'm also involved as the co-chair of the TB Accountability platform, doing a bunch of work around the TB accountability from the high-level meeting. I really want to welcome everybody today to our session at the Union, and of course, thank you to the Union for putting this on. It's really great to be able to talk about these subjects. The title today is Finding Missing People with TB, What It Will Take to Achieve the UN HLM Targets. We've got an excellent panel that's going to be talking to us about various aspects of this. We're going to be hearing from them in just a minute. I'm going to introduce them. And then we're going to move through those presentations pretty quickly to try and get some interactivity and get some questions from you and some dialogue back and forth between the audience and the speakers. Really looking forward to being able to do that. Chair's privilege, though, I'm going to take a few seconds to talk about where we're at on this. I think what we're ultimately talking about is coming out of the United Nations high-level meeting on TB back in September of 2018, just over a couple of years ago. We had some really important commitments from all member states to find, diagnose and treat 40 million people with TB between 2018 and 2022. We've all seen the numbers. The Global TB Report estimated 10 million people falling ill in 2018, 7 million people reached with TB care. That's up from 6.4 million the year before, which is quite frankly one of the biggest successes in public health I've certainly seen in all my time working in the sector. A massive increase in outreach, but there's still very, very far to go in terms of reaching the 3 million missing people from TB. Nearly 3/4 of those 3 million estimated to be accessing care in the private sector. So it's not that they're getting no care, it's just that they're not being connected to national programs and not necessarily connected to global best practice care. So we've already seen some good progress on this, as I said, in terms of those really great results, moving from 6.4 to 7 million. But as we all are aware, progress has been severely derailed by the COVID-19 pandemic. Every study I've seen shows a sharp decrease in TB notification almost everywhere we look. In some countries, up to 70%. Most countries report that active case findings have been completely halted. The focus on finding the missing people with TB has quite often been diverted into work on COVID and other related things. So what's really interesting, of course, and what we're going to hear from people, some of our panelists, is that we have been doing some really interesting, exciting and progressive case finding work on TB to reach those missing people and get them connected into care. So this session is going to really, examine that backdrop, dig into, hopefully, particularly in some of the questions and answers, how can we take the good things we know about what works in TB, bring that across into the current global health paradigm, and potentially look at how can we build back better as we recover from COVID. I think there's some interesting ways where COVID and TB programming can be brought together and really drive us to make up for lost time on reaching those big goals that all the world leaders committed to back in September a couple of years ago. So I'm going to introduce our panelists as we go. So I'm going to start out. First speaker today is Dr. Suvanand Sahu. Dr. Sahu is the Deputy Executive Director of the Stop TB Partnership based in Geneva. He's a very strong advocate for innovations in care delivery, universal and equitable access, and people-focused work. Medical doctor, trained public health specialist, 18 years of experience in TB alone, working at various levels. Dr. Sahu, really interested in hearing your opening remarks for us today. Please go ahead. And as you speak, just to let people know, I'm going to drop the names and Twitter handles of all of our speakers into the chat. So you should be able to see those. Please do tweet at people and engage through that as well. I'm looking forward to sharing it out amongst the wider TB community, not just those that can join us here today in this session. So Dr. Sahu, please take it away.
Thank you, Aaron. I'm trying to share my screen. I hope you're able to see my screen.
We can go ahead.
Okay. So I will, in the next 10 minutes, quickly take you through a little bit on the UN HLM targets, which are linked to the missing people with TB, how we are, where we are, as Aaron described, and then come into some things that are needed and some things that are happening to reach the UN HLM target despite the COVID pandemic happening. So first of all, to draw your attention on two big pandemics of respiratory infections, infectious killers. If you look at the Global Fund eligible countries, this is not the full world, you see that the left-hand side, the number of people getting affected by COVID and TB, even in Global Fund eligible countries where TB is higher in terms of burden, it's mostly higher burden countries. COVID, you can see the numbers, slightly old data, 2 weeks old, but still the numbers are higher than TB. On the right side, if you look at the deaths, TB deaths, though, are something like 4 times of what so far has happened with COVID as deaths. Now, I think right at the outset, I wanted to draw your attention onto something that we have learned from COVID. Of course, there are many lessons. Life has changed. Things have changed due to the COVID pandemic. But I would like to highlight one particular aspect of it, which has implications for what we are discussing today. If you look at how many people or how many tests have been done for COVID-19 during the last 8 months, I did that quick calculation. In just 8 months, 700 million tests have been done. Now, if you look at how many tests have been done with TB, the best test we have is the expert test, Gene Expert. If you look at the last 10 years of its existence as a tool, and if you look at the numbers, we are nowhere near. It is a small fraction of what has been achieved for COVID. If you just take 1 year, 2019, only 15 million max tests were procured. So that's the numbers we are talking about. But the need is in hundreds of millions each year for TB testing. But we see COVID getting scaled up. So that's something that we need to keep in mind. And when you ask people why it is not happening in TB, one of the important challenges is that finances are not available for scaling up tests to that level. But we did a quick estimate in a number of countries. We took the TB National Strategic Plan and looked at the budget, did a quick estimate of if the tests are costed at a particular rate for COVID-19, what would be the estimated expenditure. And we find that in some countries, the expenditure in COVID testing has actually surpassed the total TB NSP budget, which is multi-year, 5 years. So let's park this question. Can we do this kind of scale up and funding for TB as well? Now, just to quickly run you through the story of finding the missing people with TB. Here is a graph that shows up to 2018, how the trend was. The green line there is how the missing people with TB decreased as a proportion of the total TB. And you can see that dramatic decline happening. This is data from 13 countries that form the strategic initiative of Global Fund. And if you look at how it was happening then, and if you look at the data from 2019, this is a slide which shows the UN HLM targets, all of them, the numerical targets there. The 40 million target of TB treatments, we are at 14.1 million, still a long way to go. But if you look at the other ones, children, MDR TB, children with MDR TB, the 30 million TB preventive therapy, they are even below that. If with 2 years gone and 3 years to come, we don't see that kind of a progress. And let me come to the last one, which is the TB preventive therapy. Here, if you look at the progress, It is in three parts. The first one is people living with HIV. We see some dramatic progress there, and very likely we will achieve this target, and probably it'll go beyond that. If you look at the contacts, under 5 children and the other contacts, the performance has not been good. This is an area that makes us think, are we leaving behind the contacts at a very important time when the COVID pandemic is focusing attention on contacts. Now, so that was a 5-year period. If you take the Stop TB partnership, if you see the targets on the Stop TB partnership website for 2018 and 19 and compare them for the 5 indicators, this is how they score. So you can see the children on MDR TB treatment. For the first time, WHO put the numbers there in the WHO TB report, which is very good, but the numbers are really small, and that is the least level of coverage of the target. Now, I want to make also another point that we cannot achieve the treatment targets if the funding targets are not met. Here you see the funding on the TB care and prevention, which is the implementation funding. We have currently half of what is needed. If you look at the research R&D funding, less than half of what is needed. So now I move on to 2020, and as Aaron was describing, in a number of countries on the left side, you can see the WHO Global TB report. A number of countries, you can see the decline in case notification. They were all increasing in the right direction. On the right, you will find data more recent up to August, and we have actually live data for India up to yesterday. Philippines is up to the last month. We see the decline still continuing. So that is a major cause of concern. Maybe after the lockdowns, it came up a bit, but still not going up in the right direction. The modeling work that we did from Stop TB in collaboration with Imperial College, Avenir Health, Johns Hopkins, and USAID painted a grim picture of the whole response, the progress made in TB going back 5 to 8 years in terms of incidence and mortality. This was done in May, and unless something is done, probably this story will unfold, and we should prevent that. This is also confirmed by the civil society perspective that was done as a study, and the report released. 2 things to point out here: 75% of advocates in Global Fund eligible countries reported a decrease in TB testing, and 53% reported that TB funding was diverted to COVID. Now, what needs to be done to address this? This is a piece of work that we have been doing for partners and trying to push Global Fund to act on it. And this was also presented to the Global Fund board. What is being put together is being called as a catch-up plan for TB, and these are the main components. In terms of what is needed, we need to reverse the losses for TB diagnosis and treatment to pre-COVID situation, but not only reverse, but accelerate further to reach the UN HLM targets. And this will not be possible because the COVID pandemic is here and is going to stay. The TB program needs, TB responses in countries need to be remodeled. And a lot of things are needed there. And the approach that is being discussed is 3 things there. One is how can a surge up campaign be done, multi-month campaign, to come back, reverse the damage that is done. And then the second one is how can some creative way of something can be done to protect the financing for TB, especially the domestic financing, and domestic budgets are getting stretched, and also further increase it through some innovative mechanisms. We saw how COVID funding increased, so it should be possible. The third one is to use innovative approaches and tools to restore and scale up diagnosis, treatment, and prevention. And I will come just very briefly because of time constraint. I'll touch on some of them, but just focus on the innovations and some digital tools that are being used and have the potential to be used to do this. So first and foremost, I would like to focus our attention on When the health system is preoccupied by COVID and people are afraid and stigmatized, the access to health system is difficult. So the first issue is, how do we change the model to a home-based and community-based diagnosis and treatment? Many things can be done there. What has been suggested and tried out in a number of situations: telemedicine, TB testing in the community using mobile vans and diagnostics, active case finding, linking TB to other initiatives. We heard in some countries some campaigns going on for other diseases, non-communicable diseases, or maternal and child health. So how can that be linked? Provide access to modern diagnostics. So this is an opportunity to quickly switch and scale up rapid molecular tests. Now we have not only Expert, we also have TrueNat. Use of urinary lamb test. This has been underutilized, as many of you know. Scale up ultra portable X-ray, and coupled with artificial intelligence that gives us the ability to do X-rays outside the health system, and specimen transportation mechanism. For treatment, accelerating the use of digital adherence technology and use of call centers and delivery of medicines to people's home. Very important for all this, for diagnosis as well as treatment, is to invest in communities and NGOs to provide that support that is needed for diagnosis and treatment to be carried out in the community. And this is very important. A few other points that I'm touching upon. I see that Aaron is on the screen, so let me try to be fast here. Integrated TB and COVID testing and tracing. We have seen how some countries are implementing bi-directional screening, testing, and tracing. This is an opportunity also to scale up contact tracing and TPT in TB. Also on real-time surveillance data and community monitoring and feedback, also on a real-time basis. And I'll come to some tools that are available for that. And social nutrition and financial support, all very important. Smart purchasing of TB services while the public health system is engaged with COVID through the private sector is something that has been tried in a number of countries and successfully. So just to touch upon a few digital health tools, there is a note there you can see, and with a link there on our website, which describes all the different tools. But I would like to highlight 5 categories here: the digital adherence tools, which are very important for treatment, artificial intelligence for X-ray reading, lab connected diagnostics, community-based monitoring tools, and e-learning tools. And there are several examples. I would just show you some pictures because of want of time. This is Chennai city in India, badly affected by COVID. But here you can see how mobile van equipped with portable X-ray and artificial intelligence is doing a screening for TB despite the COVID pandemic. Here you can see in Pakistan how a mobile handheld X-ray is being used with similar artificial. Here are some pictures. Some are actually pre-COVID. That's why you see lots of people there. But this tool is being used now post-COVID as well for community monitoring and feedback, which will be very, very good in this kind of a situation. So I leave you with 2 websites there. One is on COVID and TB. A lot of experiences shared from countries on the first website. And the second one is the missing people with TB for 30 high burden countries, analysis of and very, very interesting presentation of data. So I would stop there. Thank you, Aaron.
Thanks, Dr. Sahu. I think very sobering to see that in some countries more has been spent on COVID than 5 years of TB budget already. I think it's important for us to recognize that money is not the only thing that we need, but it does put a pretty hard limit on the extent of the progress that we can make. And also the numbers on contact tracing are also very sobering. I think in the UK, we've trained literally thousands of contact tracers in this country. And I think it would be really interesting to see what we can do around the world in terms of really scaling up that contact tracing. It's really my pleasure to jump straight into our second speaker, is Dr. Amir Khan, a medical epidemiologist, social entrepreneur based in Singapore, founded the Interactive Research and Development, Singapore-based not-for-profit committed to improving global health and development through process and technology innovations. Dr. Khan, Amir, I'm really pleased that you're able to join us today. Looking forward to seeing some of these new innovations and hearing you speak. Please go ahead.
Thank you very much, Aaron, and thank you everybody for being on this discussion. I'm going to focus the experience from the Zero TB Karachi program in Pakistan pretty much on the search component, but from the very outset, I want to emphasize that this talk and the work that we do really is about comprehensive search, treat, prevent strategies all combined together. I will share, although the focus of my results will be on the search component, as I said. So Zero TB, as many of you will know already, is a consortium that was founded by the Tb Partnership, IRD, the Harvard Medical School Center for Global Health Delivery, and AND, which is based in North Carolina. And now it's a bigger consortium of countries, of cities that have really embarked upon jointly figuring out how we're going to be able to provide islands of elimination and control, examples of search, treat, and prevent in pretty much every place where there's TB. One of the earliest studies, one of the earliest cities that embarked upon a Zero TB initiative was the city of Karachi. It is anywhere between 16 to 20 million people, depending upon whose estimates you use. And we have had a series of global fund grants since 2016, currently active, that have helped support the establishment of the Zero TB initiative in Pakistan. This funding has been used not just for the city of Karachi, but 32 other districts in the whole country, and then subsequently been renewed for further expansion to include 2 other cities, the city of Peshawar and Quetta. So hopefully we will have more than one city with data. So here's an illustration of the country. In the south, you'll see the city of Karachi, where Zero TB Karachi has been now active since the last quarter of 2016. And it's that program that I'm going to focus on. And as I mentioned, it's a comprehensive menu of search, treat, and prevent programs. A lot of the different things that Sahu has just spoken about are embedded within all of those different aspects of TB control. They're all essential and they're all priority. Yet I will now speak about the one that I think a lot of people have their focus on, because it is a technology. Mobile X-ray based screening is a technology that's actually been around for a long time, but for many years, especially in the late 80s and onwards, it's sort of been forgotten in terms of TB control programs, because it either went out of vogue or there was suggestions by certain expert committees that this is a very difficult and expensive thing to do. However, many, many decades ago, this is how North America, Europe, many other countries were very went out and mass X-rayed populations, certainly high-risk populations, but also in the communities, and did mass X-ray screening. And it's a system that we've brought back to life. And I think at this point in time, it is best exemplified by the program in Pakistan, where we have 55 mobile X-ray vans that are deployed across the country. So if you look at the older picture on the top left and you look at the top right, which is a picture from Peshawar maybe a couple of years ago, it's just essentially the same thing is being repeated, but it's now, thankfully, we have better technologies. And now there's just no question of the utilization and usability of this technology and its maintenance in any of the settings that we work in. So on the van is a digital X-ray machine integrated with CAD software with a X-ray printer. So in the event a patient is, has a bad chest X-ray, a printout can be given to them so they can take it back to their clinical provider as well. The mobile X-ray van can truly go pretty much anywhere that you take it. And a lot of the different kinds of places that we focus on are outpatient hospital departments, prison systems, wherever you think you're going to find more TB than in lower risk populations. Because of the way this program was structured and the campaign around it as well, we had a lot of attention focused on it at its launch in late 2016. And then when the vans started coming in 2017, and subsequently we had all the vans we needed into 2018, there was a lot of free press coverage wherever the van went, whether it was a hospital outpatient departments on the top right, as you see, you'll see lines of outpatient department patients and their attendants getting in line to get a chest X-ray. or even factories on the bottom. And sometimes we take more than one van. So you could have one van sort of cater to the women workers, another one to the men workers. And of course, we got continue to get a lot of free publicity and still do in national media. Now, one of the things I wanted to emphasize from the very beginning is that what one person defines as active case finding is not necessarily what somebody else thinks is active case finding. And so you have to be very careful when you embark upon these products and approaches to be, to measure what you're doing and to be able, for us as a community, to be able to compare the intensity of what we're doing amongst ourselves. Who are we targeting? Are we, targeting adults and children? Are we, going to be looking at the total proportion of the population that we're targeting in terms of coverage? Is that an estimate that we can actually capture? Are we going to be doing rapid PCR testing? And hopefully that's what pretty much everybody is doing now. And then are we going to be able to determine whether the yields of screening at different sites are different? And that's going to be hugely important. After the capital investments made in the acquisition of mobile x-rays and the vans, the continued cost has the two specific elements that I think are key and can be controlled and need to be further reduced over time. One is the CAD software itself in terms of its cost and ongoing reimbursements to the to the vendor in terms of x-rays per the price we pay per x-ray, but also the GeneXpert cartridges that are then utilized for those patients that have an x-ray that suggests that they might have TB. And those two costs are pretty much the drivers of the ongoing maintenance and operations cost of the program. So I'm going to start immediately with the results slide. And so what happened, and I want to be very careful. So in the last quarter of 2016, we started verbal screening in the city of Karachi. And so this is the city of Karachi at about 16 to 20 million people. Between 2013 and 2015, it had notified on average 18,200 patients a year for the whole city. In the last quarter of 2016, as Zero TB started with verbal screening, the number went up a bit. But if you compare the baseline from 2013 to the quarter 3 of 2016 to what was then achieved in 2017 and 2018, there was an almost 40% increase in case notifications in a city which was already assumed to have full coverage for TB care, which meant, of course, that there was these 40% of these patients had not been found. They were part of the private sector, or they were being found because of this mass X-ray screening. So that's a remarkable, rapid increase in case notifications in a very short period of time. And it's what Global Fund and everybody else who is signed on to these targets wants to do. And it's what was achieved and needs to be recognized through an initiative like this in Pakistan. But I'll come to what I think are really the amazing results later on. Now, one of the things we've been able to do, of course, is look at the different sites we've been mass X-raying and determine where it really makes most sense for us to continue doing this, and maybe for others to learn where they might decide to go and X-ray. And so for us, the hospital outpatient department, specifically, if you were to look at the column and just go all the way down to the numbers that are highlighted, the number needed to screen and the yield, that's the total number of people that were diagnosed from those that were X-rayed, is highest, in fact, when you screen hospital outpatient attendants and patients without any pre-screening, without asking them any questions. You're just offered a free chest X-ray, come out of the van and get yourself X-rays. And one of our teams was able to do almost 430,000 of those X-rays at hospital outpatients. And the number needed to screen, you need to X-ray 84 people to find one case of TB in that instance, in that situation. At hospital OPDs, the yield being 1.2. There are other areas which we think are exciting, but the numbers really aren't there for some of the for maybe the health worker population yet. It's a newer program we've started, but again, in the community, what is clear is that when you go into the general community, you're going to find about half or less than half of the number of patients that you saw before. So it's going to take you 200 X-rays to find one person, or a yield of 0.5. One of the things that we then started seeing was that there were reductions in case notifications at the city level in the third year of mass X-ray screening. And we saw at the city level a 7% reduction, while we continue to see high proportions, 13% of all notifications were pediatric, were children. And that's important as well, because what you didn't want these reductions to happen was that some subset of the population, whether it was children or others that were missed because the focus was on chest X-ray screening. So what's clear is that we are seeing an initial rise in cases at the city, the first indication of a decline. Not very convincing, but a 7% decline. And it's a decline that we've noted. What we've also did was, of course, really ramp up the utilization of gene expert cartridge testing at the city level. And so this is the data for the whole city for 2014 to 2018. And when you look at 2017, that was the year that the majority of the screening that we did was in fact based on verbal screening, because our X-ray vans had just started being deployed. The first one was in Q2 of 2017. And then by 2018, they were all deployed. So we ended up doing a lot of gene expert tests based on verbal algorithms, because verbal algorithms are not an efficient way of testing people, because you have to run a lot of them to find the same number of patients that you can actually find with fewer gene expert tests when you have X-ray as a triage. But in 2018 and 2019, we did the same number of tests, almost in the same thousands, as you can see here. And so one of the most interesting findings that we've seen is that across the city, I'm just trying to make sure I've got the slide in there, so I'll come to this slide first. Across the city, at the city of Karachi level, we have seen a 28% reduction in MDR-TB or DR-TB case notification, and that is huge. Also, what we've seen is a doubling of the proportion of patients that are new cases. So we're not seeing retreatment cases. We're seeing now it's gone from, in 2015, if you look at 21%, and in 2019, it's 47% of all new notified DR-TB patients are in fact new cases. And so this was something that we had already projected based on a modeling exercise we'd done with David Dowdy in the past, that we were able to sustain these kinds of intense active case finding scenarios, we would actually see rapid declines in the incidence and also the mortality of disease. And we think we're now seeing this, but the strongest evidence that we have for this is in fact in one portion of Karachi, which is about 2 million people, just between 1.5 to 2 million people, between the peaks of 2017 and in 2019. And this is the area of Kurangi where Indus Hospital is based and where we have been most active. So we are now, I'm now just going to summarize in this last slide that what we have seen over this last that you can have a very initial rapid increase in notifications of all forms. City level, we saw a 28% decrease in the notifications of DR-TB after 3 years of active case finding. At the Karachi level, at the city level, we saw a 7% decrease in drug susceptible all form TBs notifications at the Karachi level, and that's just in the last year. Grants and Unit Aid grants and now Global Fund grants. That's a city. That's a portion.
Amir,
yes.
Sorry to interrupt you, Amir. You're lagging a little bit. You might want to try turning off your video and maybe just go through the last 20 seconds again. That would be really helpful. Okay. So I hope this is a little better. But I just wanted to make sure that I got these main messages across, that when you do active case finding with X-rays at this scale, what you should anticipate is a very rapid increase in case notifications. Even at a city level, we saw a 40% increase, almost 40% increase in case notifications in Karachi. You should then see, if you sustain this for 2 or 3 years, rapid declines
in at least some of these notifications, because that's what is expected to happen. You're finding patients earlier by x-raying them. You're stopping transmission. The numbers are going to start declining. And the Global Fund may not like that, but that's exactly what we all want. But it's not how your grant might be structured, but that's what we're all aiming for. We want to find the cases that weren't being found before, and then we want these rapid declines. And those rapid declines are happening. They've actually happened for DRTB across the city. They've happened for drug susceptible TB in the place that we've done the most intense active case finding by 30%. And these are the kinds of targets that the global community has been looking for. And I hope that the examples from Karachi are going to be able to suggest that this is actually in fact doable. Thank you.
Thank you, Amir. That's great. I always love having presentations about your work because those numbers are so compelling. To be able to see how with sustained and focused effort, we can really be driving impact and seeing numbers come down rapidly. It always is very, very pleasing and exciting to see that work happening. So congratulations for that. I think that often comes back to some of the difference between some of the rapid action we've seen on COVID, for example, versus the very, very slow burn that we've seen on TB, and being able to bring that focus shows that we have the ability to deliver some pretty impressive results. It's really my pleasure to introduce Rachel Force, and apologies, Rachel, for spelling your name earlier. My hands were, I know too many Rachels that have an A in their name. Rachel is the program director for Friends for International TB Relief, based in Ho Chi Minh City in Vietnam. She's actually worked in Karachi in Pakistan and also in Durban in South Africa. She's going to be talking to us today about tuberculosis amongst the elderly in Vietnam. And I'm thinking, looking at this population and given the overlap with COVID, it really couldn't be a better time to have a presentation on this. So Rachel, welcome. Looking forward to hearing what you have to say.
Hi, everyone. Let me just get this set up. Okay, 1 second. Can you see that? Okay, great. So hi, thanks for introducing me, Erin. My name is Rachel Forrest. I'm the program director for Friends for International TB Relief. And I'm actually going to be presenting a quite similar strategy as what Amir has just presented, but really is kind of on a budget. So we haven't had the same resources that Karachi's had, so we've tried to emulate the same work, but do it a little bit more targeted and a bit cheaper. So in Vietnam, in 2018, 174,000 people developed TB, and this resulted in over 13,000 deaths. Vietnam had a second prevalence survey, which actually just came out in 2020, and it documented about a 60% reduction in smear-positive TB since the first prevalence survey, which came out 11 years ago. However, the country's total burden in TB is actually now higher, and this was because the second prevalence survey used more sensitive diagnostic tests. And so between 2018 and 2019, the official estimate of TB treatment coverage has actually unfortunately declined from 83% to 57% in Vietnam. From the new prevalence survey, what we can see is that prevalence of TB really increases with age, and men have 4 times the burden that women do. Additionally, of all the people with TB, 62% of people had chest X-ray abnormalities, but no cough or prior history of TB. So if you're just doing symptom screening or looking for cough, prior history, you're really not going to be able to find the majority of people with TB. So in Vietnam, the National TB Program, the NTP, is scaling up expert testing, but really this is being used as a faster DST. So they have authorized non-governmental organizations and other programs to start using chest X-ray screening to triage symptomatic individuals away from expert testing. And then indicate expert testing for people with mild or no symptoms. So trying to target a little bit and opt in and opt out the right groups. And they're calling this the X-ray expert strategy, which I think they very coolly named the double X. Okay, so today I'm going to present a little bit about analysis of the work we've done in Ho Chi Minh City, Vietnam. We've done mobile chest X-ray screening events, I think throughout 8 provinces in the country, but I'm going to focus on work we did between March 2018 and October 2019. It's 114 days of screening in 235 unique locations. So in the map, you can see the blue dots, and these are where all of the events were conducted in 7 intervention districts, covering a population of about 3.4 million people, which is about 1/3 of the city. We really looked at older individuals over 55 years old. I'm no longer calling them elderly because I don't think anyone who's 55 wants to be called elderly. And then also among household contacts, people with comorbidities such as HIV or diabetes. And then we really tried to focus our mobile chest X-ray screening in economically disadvantaged areas. So to give you a sense of the work that we do in order to get one of these mobile chest X-ray screening events off the ground, the first thing we do is we obtain all local government approvals. We host a consensus building meeting. I think this is a really unique feature in Vietnam, where they get all of the partners together from the wards, the districts, the province, and they'll discuss the plan. Everyone agrees to the targets. Sometimes there's even like a signing ceremony where people commit to participate. And then after those events, we will go do field visits and select a location at least 2 weeks in advance, define a catchment area. And then there's quite a developed occupational health screening sector in Vietnam. So there are these mobile X-ray trucks that we can just rent, and the radiologist comes with the truck for the day and will do all of the readings. And we're paying just a little bit over $1.15 US dollars for each of those chest X-rays. So we didn't do any of the large procurement for any of our urban mobile chest X-ray screening. We also really work to maximize mobilization. So we do a series of sensitization activities, and people who will help us with this are like district and commune level government staff, civil society organizations such as the Women's Union, retirement associations, the Red Cross. We also have some healthcare workers. So Vietnam has records of every person living within a ward or in a commune. And so we're actually given access to those. We can identify everyone who's over 55 and create a personalized invitation with their name that's then hand delivered to their home. And so you can see in the picture here, they've color coded the different invitations based on which civil society organization was going to deliver them. So on the day you actually know who mobilized best. We host events on weekends so that it's really convenient for working people. Occasionally we needed to host events on Fridays, but really it's Friday, Saturday, Sunday. We also try to reduce some of the stigma of TB screening by providing screening for additional diseases like COPD, asthma. And then for all participants, we provide a small cash incentive. It's about 44 cents to defray the cost of the travel to the event. So at the screening events, there are different stations that people move between. And the first station is always verbal screening. And we have a custom-built mHealth app, and we use Android tablets. So all participants who come to the event are screened on chest X-ray regardless of symptoms. And then radiologists will immediately read the X-rays on site. So we want to capture as many abnormalities as possible. So we've instructed all of the radiologists to intentionally overread the X-ray images. And this is in line with the WHO guideline for TB prevalence surveys. We took that methodology and applied it to the mobile chest X-ray event. So anyone with an abnormal chest X-ray is asked to produce a spot specimen, and they're given an instructional aid to help teach them how to actually cough up that sample. End of the events, we transport the samples to a local government facility for expert NTB-RAF testing. So again, we haven't done large procurement. We use the existing machines, and we provide cartridges to the government to support this increased level of testing. We also will do LTBI testing. So here are images of TST being injected, but we also do IGRA testing. And then, as I mentioned before, there are optional tests for COPD, asthma, hepatitis, blood pressure, diabetes, etc. At the end of events, we send healthcare workers out to all the homes of the people who did not produce a specimen at the event. Those diagnosed with drug-sensitive TB are initiated on treatment, at a district TB unit, and those with RIF-resistant TB are referred to the provincial level. Okay, so now I'm going to show you some data looking at the yields at each step of the TB screening cascade, and then we've disaggregated them by cough duration, age group, and gender. So a total of 34,529 participants were screened by chest X-ray. This is about 300 people per day. We try to get 150 in the morning, 150 in the afternoon. Over 4,700 people had their chest X-ray image classified as abnormal. And then we were able to test 56% of those people using the expert assay. So screening resulted in the detection of 256 people with expert positive TB. That's about 9.6% of those tested. And that's an overall prevalence rate of 741 per 100,000. So 2/3 of the people, participants who were mobilized and who were diagnosed were over 55. And I think this really shows that our community mobilization worked for the target population. And then 84% of participants diagnosed with TB were male. So just 27% of all participants, that's this 9,430, reported having a cough of more than 2 weeks. So this cohort of participants had significantly higher chest X-ray abnormality rates, sputum collection and testing rates, and expert positivity compared to those in this fourth column without a cough or a cough of short duration. Participants with prolonged cough had a TB detection rate of 1,357 per 100,000 screened, and this is compared to 510 per 100,000 in the group with the no cough or short duration. However, if we had just looked at those with a cough over 2 weeks, we would have missed half of the people diagnosed. So only 50% of the total number of people diagnosed, 128 out of the 256, were detected among participants with a prolonged cough. So more than 50% of older people had subclinical and low-grade TB, and that's the same as men. More than 50% of men also had subclinical or low-grade TB. So in conclusion, programmatic chest X-ray screening can result in high yields of TB among key populations, such as older people, that are often missed by existing government health services. The Vietnamese XX strategy found an expert positive TB prevalence rate more than 2.5 times the expert positive TB prevalence rate from the prevalence survey in the southern region of Vietnam. And I think I said this before, that this indicates that our community sensitization and mobilization efforts were effective. Half of the detected TB was subclinical or low grade. So enhanced case finding activities such as this are needed in order to improve coverage and treatment and to reach the targets and the commitments that were made at the UN high-level meeting. The XX strategy is more complex, and there's another study we did showing it's more costly than the standard of care, which is AFB smear with symptoms. So it does require additional resources in order to scale up and sustain the types of strategies that's needed and necessary to end TB. So we'd like to thank our partners and our donors. And in the last minute, I would just like to say that Vietnam has done a really great job containing COVID. We've now gone over 40 days without any cases diagnosed in the community. And we've been asked to increase the volume of events that we do, the speed at which we do them before the end of the year. We will be hosting over 100 events in over 100 locations, and we will be doing kind of passive. We'll integrate COVID in TB screening and kind of look for COVID passively. So we can talk about that more in the Q&A if you have questions. But thank you very much.
Thanks, Rachel. That's a similarly inspiring presentation. I mean, I was just really struck by the way that you've got these events embedded in the community and really working through existing systems to meet people where they are. I think we're sometimes accused of biomedicalizing the response to TB, and this really seems to be a long way from that. Also, fabulous to see that you're reaching new audiences and finding cases in a way that would have been very hard to detect using existing systems and programs. That's exactly what we need to be doing. So thank you very much for sharing that. We now move on to Dr. Andy Ayo. He's the Chief Executive Officer and Project Director of ECEWS UNOPS TB Reach project implementing a TB case finding grant in riverine and hard to reach communities in southern Nigeria. Over 13 years of experience in leadership and management of all sorts of different high impact projects around healthcare, delivery, education, economic empowerment, and others. It's really our pleasure to have you here. I would also say keep the questions coming, folks, in the Q&A and in the chat. We are seeing those. We are giving some responses as we go. So by all means, of course, give all of your attention to Dr. Andy Ayo, but do keep that conversation going alongside as well, but, while we move towards the full-blown Q&A that will come after all of our speakers have spoken. Please go ahead, Doctor.
Thank you, Aaron. Appreciate the opportunity to share a story here. So my name is Andy Ayo. I'm the Chief Executive Officer, just like Aaron said, for Excellence Community Education Welfare Scheme. We are TB partners in Nigeria, and we're getting some funding from TB Reach Grant to support active case finding. We have a long history of working with various partners, the Global Fund, particularly now with TB and HIV, as well as PEPFAR, CDC. So my presentation will basically provide us a brief background of situation in Nigeria, and then we'll do like a COVID-19 case update for the country. And I'll quickly go into the challenges that ensued when we were just about commencing our project this year, and what we were able to do and what we've been able to achieve at this time. Thank you so very much. Next slide. Thank you. So Nigeria is, as you all know, is about the most populated country in Africa. And, you know, we have a high TB burden, about second in Africa. And we see around 470,000 diagnosed cases in Nigeria every year, and you know, about 154,000 deaths annually. And so this accounts for about 15% of the global missing cases. You know, the various challenges within the healthcare system in the country, weak healthcare structure, and poor access to healthcare services, and overcrowding, particularly within the population that we currently do support. We support a lot of the riverine communities and very hard to reach areas wherein healthcare delivery is almost absent. There's a poor knowledge and access to TB. In many cases, poor vaccination coverage because of the difficulty of getting into some of these areas, and the trade of the people, their malnutrition, high HIV prevalence. These are all basic factors that continue to fuel the TB epidemic in Nigeria. Yeah. So I'll be zeroing in, I know, my colleagues have been talking basically about the broad spectrum, but I'll try and zero it into a particular project that we've been implementing with funding from TB Reach. Is actually in the scale-up stage at this time. So basically, we've been working in about 15 communities in the southeast, south zones of the country, particularly using innovative approaches with community volunteers and private pattern medicine vendors and community pharmacists, basically looking at the PPM approach as well to active case finding and linkage to treatment. And really, what is fairly unique about what we're trying to do is, we're really targeting border communities where there are riverine fishermen and sometimes very hard to reach communities with a real collaborative approach, trying to help the state, working closely with the NTP and the state's TB program to access areas they haven't gone to before. So I'll just go the COVID-19 situation in the country this time, fairly maybe as of Monday of this week, we had only 61,558 cases notified. And we had tremendous amount of discharges, about 56,000 over, and just a little over 1,100 deaths. As you can see, well, we've done barely not up to 600,000 tests, and we're a country of 200 million. So that still creates a bit of a challenge, because when we look at the percentage per population, it's quite very low. But however, we've also noticed a bit of flattening of the curve. Within the states that we support, we've noticed, the epicenter of the epidemic was in Lagos, which currently has over 20,000 cases. And as opposed to where we work, which is just roughly the highest, Delta State is going up to 2,000 cases, and then Cross River, less than 100 cases recorded at this time. What was really interesting for us is that, I mean, the first index case was found in Nigeria late part of March. That was while we were just concluding our training of the community volunteers and trying to hit the field to start work just 1st of April. And all of this temperament, and as you all know, I've told you know, Nigeria has a high burden for TB, and the truth is, even when people are getting infected with COVID, they still at a significant risk of the TB infection still continues. So this played a very significant role in our decision-making processes to, do we continue with this intervention? Do we put a hold on it? So what do we do? You know, the COVID is a real disruptor, but we salute the courage of our people who went far in doing work, and also the work of the NCDC, the Nigerian Center for Disease Control and Prevention, has been quite active in trying to ensure that we have access to as much information as possible and data. The next slide. So, you know, this, just what I was saying, the issues were pretty clear. We're just on the verge of commencing our case finding, and we didn't notify this. It became, you know, the lockdown systems, you know, started off somewhat in the April section. And like I said, we had to come together as a team and make our minds, talk with the state, the NTP, work closely with guidance from the Presidential Task Force and other NCDC guidelines to say, what do we do? Do we halt this? But I think when we looked at the comparison in terms of the case notification for COVID in the epicenter, which was actually in Lagos, which is miles away a bit from some of where we are working. And the fact that, yeah, the epicenter stayed between there and the Federal Capital Territory, and then, but it was silting downwards and the lockdown was beginning. We said, well, let's get more information. So there was a real anxiety in the air. There was, as you know, significant lack of awareness on COVID, both within the healthcare workers, our frontline healthcare workers were also apprehensive as to, yes, after the training, so they're supposed to hit the field, the local government, TBLS, and you know, the state TB program managers, they were also, you know, having this conversation with us. And, you know, there was significant dearth of PPEs, which, you know, which is, we all know, is very important at this time. Yeah. Next slide. Again, there was, you know, closure of some of the service units in some of the hospitals, you know, sometimes conversion of those points to supporting the COVID response, which was more like a big emergency. In some cases, just shutting down those service units. And because of the fear of contracting COVID, even by the healthcare workers, we didn't have sufficient information at that time. And as you know, we already have a human resource for health issue, but so there was strategically insufficient healthcare personnel. A couple of them were also being channeled into COVID testing and potential responses in terms of contact tracing for COVID. And that didn't help healthcare workers, you know, incentives, they wanted more. If we have to go to the field, maybe we're going to get more incentives beyond what you're able to provide. And issues like community outreaches, I mean, the lockdown was pretty intense. There was no intercity movement. I would say that that also helped us in some sense, because where the epicenter was in Lagos and in FCT, the ability for people to move in between those wasn't easy. So what did we do? We decided to tie our loop very strong with the NTP and the STP and try to get our people, our frontline healthcare workers, essential officer status, which allows them to move around in the middle of the lockdown. This was very strategic, as many projects had shut down and the people couldn't move around. Only essential workers could move around. And, you know, we provided them like introductory letters to communities and generated ID cards for them. And, you know, we, working closely with the NTP and the COVID response mechanism, we're able to identify key resource persons who would provide very significant training for our people. So there was significant training on COVID-19 as the pandemic and TB. So how to differ. People needed to understand if you're hitting the field, and then also observing all of the COVID-19 responses was pretty important. This was equally stepped down by mentoring to the frontline providers, the community volunteers, the pattern medicine vendors. As you know, in Nigeria, we have a huge league of these pattern medicine vendors. They're not pharmacists, but the locals who learn a bit of the pharmacy, and over time they dispense drugs, and also community pharmacies. So the training went across for them, the DOT officers as well as the local government TB people. That was very strategic to taking away the fear factor and maybe entrenching a bit of courage for our people to hit the field. Yeah. Next slide. Okay, excellent. So one of the things, as you saw in the picture before now, you saw some of our people trying to hit those communities in Bielsa with their N95s. So we're able to purchase and distribute PPEs, and thanks to TB Reach for the understanding, and hand sanitizers, hand gloves. We also provided them with, we usually would provide them with reflective jackets, and also, what their floaters for when they have to hit the water. And one of the things that we strategically used was also the use of virtual technical assistance support. We used a lot of remote approaches to providing support as opposed to the one-on-one visits. So phone calls, WhatsApp messages, set up Zoom meetings. So we limited our ability to do all that. And then, the success is very clear that within these couple of months, we're able to sensitize close to 200,000 individuals, and of which over 12,000 were presumptives and tested as well. And you would see that the lab confirmed TB, we had about 503 of them, and all forms 689. This was pretty, it just told us one thing, that if you didn't do what you were doing, yes, those guys, some of them at this time are already due. I mean, they finished their medications, they're already doing great. They probably would have gone away just with the fear of COVID. This tells us a little bit about what happened in the first month. So you see the blue has to do with the April. So April was the inception of the lockdown. So you could see the graph in terms of people that we're able to reach, which normally would have actually sensitized a lot more people than this. But the lockdown made it very difficult. Using house-to-house approach wasn't that easy. But then, this is what we could notice, that going towards June, when the lockdown began to relax, we went up to 42,000, and then 45,000 in the month of August, went into the interstate movement, and a lot of relaxation of the measures for COVID. And you would also see the same even within. The beautiful thing is the yield was also almost about, for presumptives, for all forms, about 6%. And so, it was pretty significant across the various months. Yeah, next slide. You will also notice very carefully that, in the first month of April, we got about 94 cases. So it's almost like a reach there for back positives, which actually had to depend all on, access to the gene experts and sites and all that. And in all forms, yeah, we introduced a bit of the chest x-rays, and that took a jump on the numbers. So you could see the trend, taking it from April, just showing how the lockdown relaxation had impact on potential new cases found and new cases put on treatment. Yeah. So in conclusion, I would say that COVID-19 has really, highlighted a lot more the weaknesses in our healthcare system. It's made us, that's why, and thanks to all the partners, but it also created opportunity, allowed us to see the need to using a lot of telemedicine and real support to our systems in terms of using remote approaches, which I think has changed the approach in all for what we continue doing from now going forward, including holding meetings or trainings. I would want to reemphasize, so the trainings that we held all were done with Zoom, and so we never had a one-on-one contact. And then we used, it was also not easy even getting supplies within this time. So obviously we had to get partners who had ability to move around in the middle of the lockdown, and it was pretty expensive. But I thought the people that we got then was important, and those guys are on treatment today. So also that investing in safety, I mean, we've always talked about hygiene, but I think COVID-19 era has actually re-engineered our approach to hygiene in terms of ensuring that guys use their face mask, and all frontline healthcare workers, they use hand sanitize as much as possible and keep social distance. And even when they are collecting samples or delivering those samples, there's much more attention to detail in terms of what they do. And also really has made communication, use of various approaches to communication, in terms of multiple step approach to demand generation become important, and not just when you have to see, which for me has been the traditional method over the while, but that has changed. And it reemphasized that communities have a big role, and we know that to play, and they should be strategically, engaged. Yeah, so we think that a lot needs to be done. Yeah, some of the pictures just showing some of our friends with their N95 that's in Bielsa. The others, basically trying to get on board. Gene Expert facility, sort of mini training going on there, but mini outreaches and hard to reach areas that the work go on. We're very grateful to our funders, the Stop TB Reach organization, for their support, and other support systems that we have. Our team also led by Dr. Valerie, Dr. Okezie Favor, they've done amazing work. They've shown tremendous courage in the middle of the fear. And what is really important here is that they were able to overcome the fear of COVID. Thank you.
Thank you so much, Dr. Ayo. Really inspiring to see how adapting a program in real time to a really critical new public health threat and making that really work. Very, very powerful stuff. I'm going to move straight on to our last panelist. It's Blessy Kumar. Blessy is known to many of us. She's a health activist with a background in community health and health systems management, and very importantly is the co-founder of the Global Coalition of TB Activists. Extensive experience working with varied marginalized communities in India and internally displaced populations in Sudan and all over many other countries in the Southeast Asia region. Blessy, I think we'll go straight to you in the interest of time so that we can make sure we have some time at the end for questions. So please go ahead, Blessy.
Thank you very much, Aaron, for that. And I'm going to be giving you a little bit of a ground level perspective. The co-panelists have very, very well established and shared with us, how the people who are not in our care can be found, and we saw some excellent presentations on that. But what would it really take to, achieve the UN HLM targets from a community perspective? So when in 2018 we had the UN HLM and there were this very, very ambitious targets, we were very kind of encouraged and pushed to move towards achieving them. Next slide, please. And then the recent report of the WHO was quite sobering, actually. And but the reality is that all this is not because of COVID. We were already lagging behind before COVID. And of course, COVID really derailed our progress and brought us back. We've heard our panelists really share at what we stand to lose, if we don't safeguard, excuse me, if we don't safeguard the gains of the past few years. Next slide, please. So we already had challenges before COVID. We had huge burdens, and referring to a country like India, where I'm based, very, very high burdens. We had high death rate. We had high drug resistance. And we were struggling with the time taken from the onset of symptoms to correct diagnosis. Patients were running from pillar to post to get the right diagnosis, and sometimes it took months. In many countries, as it showed through our civil society community survey that was recently conducted and the report was launched, that the health systems in many countries were already weak, and they were further weakened for TB by COVID. Stigma and discrimination was a huge barrier and continues to be a huge barrier for access. And also many of our countries struggled with the reluctance or the delay and lack of resources to very quickly adopt new tools. There was really, the traditional mindset didn't allow for that to happen really quickly as it should have done. And then, of course, finding the missing people. Yes, we have made some progress from the presentations of our other panelists, but the millions continued even till today. So the challenges during COVID, there was complete disruption of services. Health systems were really ill-equipped to respond to COVID and TB. As you can see from the picture from NDTV, there was a lot of migration. The migrants, daily laborers that came to the cities started moving back to their villages. And there was complete disruption. There was no transport. We heard horrendous stories of people walking for hundreds of miles. You see the little baby lying down on a suitcase that was being pulled by a mother, left a mark in our minds of the struggles that people were going through. There was impact on the people seeking and receiving care. It was reduced by 60 to 80%. And the survey report clearly states that in India and Kenya, this was really around 80%. And then there was the shifting of focus and resources from TB, which was really a big hit for us in the TB world. Like others have already mentioned, if we had the resources and the attention and the focus that the last 6 to 8 months have had on COVID, if we had spent that for TB in the past decades, I think we would be much, much closer to achieving these targets. But unfortunately, whatever little was available was being diverted. And then the marginalized were further marginalized. There was increasing impoverishment and social isolation and increasing inequities and human rights related barriers were augmented and multiplied. But there are also opportunities in COVID to learn from and, increased testing that we saw for COVID. The increased funding that we saw for COVID, especially around R&D, the millions, hundreds of millions that has been spent in these few months on COVID. How can we leverage that for TB? But the question is, the missing continue to be missed. And I think we need to really start looking at where are the missing? Are they the migrants? Are they the private sector? There are many. 3/4 of these people that we say are missing. We hear that they are in the private sector, but do we have proper data for that? Are they the prisoners? Are they the people living in the slums? Are they the sex workers? Are they the tribals who live in remote areas? We really have no data. We also don't know why they are missing. Is it because the last mile services are not effective? Is it because the national TB programs are not reaching them? Is it because the TB programs are not partnering effectively with civil society and community-based organizations, which reach them and provide the last mile services? Next slide, please. So what is really needed to find the missing people? We need strategy and approaches to get data of the missing people. And we need people-centered services. Services that really respect and protect the human rights. Services that combat stigma and discrimination. We need granular planning at the micro level. We need to focus on vulnerable and inadequately served populations. We have in India started working very closely with the All India Network of Sex Workers and the people who inject drugs. And we have been hearing, information from them has been so rich about the challenges, especially around TB, that we are facing. So I think as TB programs, we have to be proactive in reaching out to them. And we have been also working with our national program to bring the attention to the insufficiently served populations. We need to really look at the last mile services. We need to look at investment. I mean, it is possible. We have seen and learned from COVID. How do we leverage? What should our messaging be? How do we demand for that investment? What can we show as evidence so that there is more investment? We need to collaborate effectively with different players. I mean, if 3/4 of the people who are missing are in the private sector, how are we going about in engaging and bringing them in to that TB response agenda? The recent TB Reach grant very specifically focused on private sector, and I think this is a great way forward. We need to look at civil society organizations really seriously and partner with them effectively. The communities, I mean, they are the best placed to find the missing people because they know, and we need to start listening to communities. From COVID, we also learned the effective communication results that can happen. And every day we see that this is being played on radio stations, mobiles. We need to learn from that and be innovative and clever and be willing to be different to play, kind of play this game of ending TB very quickly. So what is the comparative advantage that civil society and communities have to bridge this gap of the missing people? If we have to achieve our targets that were so ambitious, that left us with so much of hope, we need to really start doing things differently. While we go about with our plans of how to find the different strategies, we cannot forget to look at communities. We cannot not listen to what communities are raising as issues. And we need to also support communities to put that information in a way that is easily understood, in a way that can be presented in a scientific manner. Communities can bring a unique perspective that is not available for anyone else. Only the communities can do that. And the real data from the last mile recipients. So whatever the national TB programs plan at the center, to know whether that's effective at the ground level, we need the communities. And they can provide that real-time data. Communities provide us data that is evidence-based. From the Stigma conversation books that we have produced, we know that stigma really destroys the core of people who are affected by TB. It destroys families. It completely blocks access. So I think we need to look at the evidence that communities are bringing. Communities are also best placed to provide valuable guidance. We don't look at communities as a source, a valuable source that can actually guide us based on those ground realities, both through the lived experience of having survived TB and also through the experience of service delivery at the last mile. The recent human rights policy brief has been a great example of communities actually giving guidance to policymakers, to national TB program implementers, which was accepted globally, welcomed globally. And I think we need to start looking at this. Communities also have been able to unpackage the guidance that is coming from WHO, from other technical agencies, has been able to unpackage that into a language that is understood by the community. For example, the TB Preventive Therapy, where a lot of questions were answered. We worked with Southeast Asia Regional Office of WHO to bring this. And it is being used by communities across. It's being translated into many languages. And it's a very simple brochure, but it is something done by the communities who understand what it takes to unpackage those huge guidelines. Then, we are also, communities are best placed to provide, guidance on training. How do we train people? What are some of the important things that we should be training for, TOT, training of trainers, who can then go and train people who are affected by TB, other insufficiently served populations, so that they can train others in their communities. Civil society can and also provides those last mile services and can support the national TB programs greatly. And we also have real-time reporting of challenges. Civil society and communities are the first ones to alert regarding drug stockouts, regarding some economic packages not reaching, nutritional packages not reaching, and they can really report that very quickly to the national TB programs. And knowledge of where the missing people are. This really rests with the communities. Thank you very much.
Thank you, Blessy. Excellent summary of where we are and where we need to go and how communities can play a part. I think that was a really powerful intervention. Please excuse me. We have about 10 minutes left, maybe slightly less. And so we're going to go to do some Q&A with our panelists. So I don't know if panelists, you want to jump yourselves onto video as we do that. If you'd like to ask a question about panelists, you can ask them in the Q&A, it's button down the bottom, but you can also send a message to the panelists using the chat function, or if you'd like to speak, do raise your hand and we can go to you to ask a verbal question, or if you'd like to make a verbal intervention. So give people a couple of seconds to get their hands up. But we do have a question. Right, hang on, here we go. Right, we do have a question coming through here in the Q&A, which maybe we'll start with. I'll just read it out. Thank you for the presentation, progressing and enjoying. What did you exactly do to improve the interest of TB clients from marginalized groups to come to treatment with confidence, but without fear of stigma from their neighbors and dominant groups dwelling in their area? I think almost all of our panelists could answer that question in different ways, but maybe just one or two. Does somebody want to jump in there? Just Dr. Amir Khan has just let me know that he's having some technical details getting his camera on, but he'll join us in a second. So I don't know if anybody, any of our other panelists want to jump in on that?
Maybe I'll just go while we wait for the video to connect. Can I be heard?
We can hear you fine. Please go. We'll use our imagination for your visage.
So the marginalized groups can vary in different settings. One of the most important marginalized groups in our setting in Karachi who are women, who often don't have permission to come out of their homes to go out to a facility or to get into a community camp for a mobile X-ray van. So we used other adolescent schoolgirls to empower access into the household and information into the household to bring these women out to get themselves X-rayed when the vans came in the neighborhood.
Thanks, Amir. Does
so,
anybody else?
Yeah,
please go ahead.
So thanks very much. So well, the population that we do serve in Nigeria, basically the fishermen community, are pretty marginalized because they're sort of they live in the hinterland, they go into the river to get fish and all that. They're very far away from healthcare services and so one of the things that we did, and it pretty much sometimes don't feel part of the main community, we got community leaders. So we're able to do a significant level of advocacy, and we were able to identify some community leaders among them. And through these community leaders, training and advocacy, and getting them to really appreciate, because also the issue of TB has a lot of stigma, so people may not even come out. And also intertwining it with other like NCDs, non-communicable diseases, like, you know, and then providing some minimum checks for blood pressure, sugar, sort of brought people out so people think differently. And also integration with MCH, so some malaria level projects. We are very malaria endemic country, and so there's a lot of malaria programming going on. And so integrating with those services allowed them to come out at the first instance for sensitization, which allows, and then you have the immediate support system from the NTP to link them up to treatment. They're pretty much trained to ensure that they try and kill that stigma. We can't say we've gotten it all wrapped up, but you know, it's allowing us to make some progress with this population. Thank you.
Thank you, Dr. Ayo. Does anybody else want to weigh in, or should we go to some more questions?
Yeah, so I don't know if I can quickly mention something. So I think it is very important to, as Amir said, these are different settings and different kinds of marginalized group, but it'll be very important to plan the services involving them and stepping into their shoes and looking at what they need, because they face certain barriers. We have to break and dismantle those barriers. Otherwise, it will not be, we will not be able to reach them. And I think that concept should be very important. If you do it the other way around and health system trying to say that you come there, it may not work. So just wanted to highlight that. Thank you.
Yeah, just want to mention that, you know, combating stigma especially has to be a national strategy. You know, your NSP cannot leave that out. And one of the, you know, very positive things that has happened in India is we really pushed our national TB program to have this overarching national end stigma strategy, and they agreed. And for the past 10 months, we have been working with them to develop this. And they really allowed us, gave us the space to design this. We are in the process of finalizing it. And it will be, before the end of the year, it will be launched. So I think this is a good, you know, best practice that we can take. It has to be owned by the program. It can't be something that only the communities or the civil society, you know, kind of handle. It has to be something, just like you would push for diagnostics, treatment, the National TB program, as part of their plan, has to have strategies that will work towards ending TB stigma. Thank you.
Thanks, Bessie. Rachel.
Yeah, I would just say in Vietnam, we did take it into account. You know, people felt stigma, so we tried to market the mobile chest X-ray events more as like a general health check or lung health check. And then we worked really closely with a lot of partners that were not typically health care workers, so neighborhood cluster leaders and women's unions. And so when we would invite people to events, they saw all of the political commitment, and they know these leaders who have signed on to the plan, and it really helped increase confidence in, you know, in what we're doing.
Thank you. We have just 1 minute, so I'm going to do a quick fire round with the panel to round us out. One sentence answers, please, or we will go over time. The organizers will get grumpy with us. Could you give me what you think would be the one thing that you'd like to see in a combined TB COVID response to make sure that we can reach everybody that needs to be reached? Does anyone want to go first on that?
Okay, just integration of testing and contact tracing. If we can integrate those two, will make sense, yeah.
Thank you.
So if I can say something on this. So I think it is very important to go for testing, tracing, and financing, and follow the same kind of trajectory that COVID went, and that can really pull up back TB into the track that to reach the UN HLM. Thank you.
Thank you, Dr. Sahu.
I'd like to say that do for TB what you're doing for COVID. Don't shift your focus away. And yeah, that's it. Thanks.
Thank you, Blessy. Rachel.
So while I agree with the others, I would also say adequate PPE for our healthcare workers. We need to protect them as we're doing this work.
Absolutely, couldn't agree more. Fabulously important. Dr. Amir Khan.
They're both pandemics. They both need to be treated the same.
Thank you so much. A big thank you to our audience. You've been wonderful. Thank you for all of the really smart questions in the question and answer. And of course, a big thank you to the organizers at the union, WASWA, who's been helping us out. Also, above all, thank you to all of our panelists. You're here representing so much work that you're doing in the field in so many different countries. These are real people that you're helping, and with the programs that you're running, the increase in case notification and not just numbers, those are people, and that really matters. So thank you for everything that you do, and thank you for sharing that with us today. I hope you've all learned something new and gotten inspired about what we can continue to do better. And really enjoy the rest of the union conference, and looking forward to carrying on this conversation in the coming weeks and months. Thanks so much.